So now we are live on the YouTube. We wait for a few more minutes for our people to join, and then we'll start in a minute or so. Kemche Hemant, are you back? Can't hear you. You have to unmute. You have to unmute, Hemant. Yeah.
No, I am in
Still
California,
okay.
in my brother-in-law's place.
Okay.
It is 6:30 in the night.
Okay.
Last night, તમારી પાછળ છું 13.5 કલાક.
Yeah.
But every time I used to miss because of I am traveling and my family is taking me here and there.
Right.
It is raining outside and suddenly I realized 6:30 એટલે સવારે 8 વાગ્યા છે. Let me join the soldiers of academics.
Good. Jagdish bhai, good morning. Jagdish bhai,
Good morning. Good morning.
Good morning, sir. Good morning, Jagdish.
Good morning, Hemant. Yeah.
Dr. Vasudev, Dr. Jagdish bhai Patel, no? The name here is Kokila Jagdish. Both are the respected senior doctors in our town.
Yeah.
And
Thank
Jagdish
you.
bhai is a surgeon, but he is a secretary of a trust which runs a very good, children hospital for last more than 40 years now. KGP Children Hospital. So he is a role model for us in terms of a lot of things that he does in his life. So pleasure to introduce
Thank
Dr.
you. Yes. Yeah. Nice to have you, Dr. Vasudev from Delhi. Yeah.
Thank you, sir. Thank you.
So it's about now 4 minutes past 8. So I think we start the meeting. So welcome, friends. Welcome back to Saturday meeting of Baroda in the morning. Today we have a very special guest speaker with us, Dr. A.S. Vasudev. He is a senior pediatric nephrologist from New Delhi. And his CV is very long, but briefly I'll mention few things. He is affiliated to Apollo, Max, and Holy Family Hospitals at New Delhi. He is Vice Chair, Pediatric Kidney Foundation, visiting faculty, Wisconsin, USA. He is editor of several books and guidelines which are published by IAP and Nephrology Group of India. And he has several orations and awards to his credit. He has more than 50 publications in national and international publications. And most important, he is a very popular speaker at national and international platforms, a close friend of mine, and always impressed with his delivery of presentation about his clarity of thoughts, crisp messages which emerge after his talk. So it's a great pleasure to have you, Dr. Vasudev, in our Saturday Club morning meeting. So now over to you. He is going to speak about common micturition disorders and enuresis in children. So you'll speak for about 40-45 minutes and we'll keep 10 minutes for interactions. Over
Thank
to you.
you.
Dr. Sudhim.
Thank you, Dr. Pandey, for your kind introduction. And a good morning to all my dear friends who are on the platform and off the platform, and especially to the friends from North India who are reeling under extreme cold and in early morning, they are with us. Thank you very much. As already introduced, I'll be speaking on common micturition disorders in children and also the nocturnal enuresis part, which is so very important for our day-to-day practice. So can I share the screen now?
Yes, please go ahead.
Is it visible?
Yes, yes.
Okay, fine. Right. So, dear friends, I'll be, as already said, I'll be talking about the micturition disorders, which are also called as voiding dysfunctions and also nocturnal enuresis in children. So, first of all, I would like to apprise you about the, sorry, this is the second slide, about the normal bladder function. And if you see in this slide, this is the normal bladder, which has a detrusal muscle, which relaxes when the child wants to pass the urine. Urethral sphincter contracts and pelvic muscles contract. So this is the normal structure which the child would have at any point of time. When there is first sensation and the bladder is partly full, half full or so, the urination is voluntarily inhibited until the appropriate time and place is there, so we can all inhibit the urination. When the normal desire to void comes, at that time the detrusal muscles contract, the pelvic floor relaxes, and so does the sphincter, and the act of micturition is completed. So any of the problems with any of the components here can lead to voiding dysfunction, whether it is in the muscle, whether it's in the sphincter, or the pelvic floor muscles, or the detrusor. So any of these components, if they are not functioning well, they can cause dysfunction in the voiding. Before I start, a couple of common things I would like to highlight, and couple of common things. One is that we must know about some of the things like child should have a drinking and voiding diary, a daily record of time and volume, fluid intake, time, and urine pass. That is the requirement we would have whenever we are dealing with such cases. Apart from that, normal number of voids with the child should have is about 3 to 7 per day, and increased daytime frequencies when the child is passing more than 8 times urine in a daytime when he is awake, and decreased frequency means less than 3 times. If you see the overview of the voiding dysfunction, the voiding dysfunctions can be divided into 3 categories. One is the neurological causes, which are suggested by the history and examination. That is a lecture in itself. Then anatomical causes, which are depicted by weak urinary stream, straining, and never normal voiding in a child. Again, a very detailed topic. What I'll be talking today is the dysfunctional causes, where there's absence of neurological and anatomical lesions, and these conditions we'll talk about are overactive bladder, excuse me, daytime frequency, dysfunctional voiding, which is non-neurogenic, giggle incontinence, then vaginal reflux, underactive bladder, and nocturnal enuresis. So I'll touch upon all these conditions one by one, and finally the nocturnal enuresis. Now, to start with, this is a 7-year-old girl who comes with increased frequency and urgency of urination. How should we proceed? Logically, if we see, we would suspect urinary tract infection in this child. But why a young girl would have UTI? And what are the other things which we think of if it is not UTI? The other things is voiding dysfunction, which has got similar symptoms. Here, a detailed history will help us, and when to suspect that this child is not having UTI and having a non-UTI voiding dysfunction. If it's a daytime urinary incontinence in the school age or previously toilet trained children, if there's persistent urgency or dribbling or pain during urination, if the child has VUR, recurrent UTI, chronic constipation or encopresis, all these can lead to voiding dysfunctions where the underlying cause may not be UTI, but other reasons. So if we see this child, he's a 12-year-old boy. This is not showing, okay, this is showing the full slide. So the diagnosis has already come here. This is a 12-year-old boy with increased frequency of micturition, urgency, daytime incontinence, enuresis, constipation. And if you see here the voided volume of the urine, he's passing urine multiple times when he's awake. And the bladder capacity expected is 175. And if you see, he's passing all small voids, about 11 voids. And apart from that, he has got constipation. He's wetting bed in the daytime also once, and also having enuresis. So what is this condition? And this is what we call as overactive bladder, where the anatomically the bladder is normal in size, but has a small functional capacity and very strong contractions. So if these children come to your clinic, while you are talking, examining, or taking the history, they would, after a few minutes, ask to go and pass the urine, and the mother would also say that he would keep going to the washroom very often, and the complaint comes from the school also. So this is what condition what we call as overactive bladder. So what do we do for these children? How do we help them? Managing the overactive bladder, first thing, we should have a timed voiding. I normally tell them that put an alarm, and after every 1.5 to 2 hours, the child should pass the urine, and gradually we can increase the duration between the voids from 1.5, maybe 15 minutes, 20 minutes, and again to 15 minutes, 20 minutes. And apart from that, we increase the fluid intake in these children and avoid certain things which are irritant to the bladder, like caffeine, tea, coffee, citrus fruits, carbonated drinks. They would normally irritate the bladder. Then Kegel's exercises are very helpful in controlling the urge to micturate in these children. We all know about Kegel's exercises. We give the instructions to the pregnant mother. So same thing can be done for the children. Treating constipation is very important because this can be an underlying cause for recurrent frequency and overactive bladder. So again, and you would see that almost so many children in your clinical practice would have this problem of constipation. Now, once we come to the drugs used are anticholinergics, and we can use oxybutynin in this dose given twice a day, or replace or tolserodine also, which has got lesser side effects. But once we go give anticholinergic, we should be very careful that the child's constipation is taken care, because these drugs can aggravate constipation also. The child may start getting relief, but it will take some time. But once the relief starts, the treatment has to be long. It cannot be like days or weeks. It has to be many months, because they take long time to respond, and longer duration for those who take time to respond. And again, once the child is responding, we don't have to stop the drug immediately. We have to taper gradually and see the response. And in the meantime, help the child with other factors. Now, coming to another very common condition which you would see in your day-to-day practice is the increased frequency, which is also called as polycyuria. And if we say about polycyuria, this is a Greek term which means increased frequency, and this presents as acute onset of urinary frequency in a previously toilet-trained, well child, small voids, 10 to 15% of expected bladder capacity. So if you see, this is an acute onset. Suddenly, these symptoms will start that the child is passing urine every few minutes. Frequency is there. In a previously the child did not, he was well and no problems. And the voids, if you measure, they are very, very small voids. You would pass at least once per hour, or as frequent as sometimes 10 to 15 minutes also. So these are the children, when they are sitting in my clinic, and I'm talking to every 2, 3 minutes, 4 minutes, they would say that they want to go to the washroom. Then I engage them in the talks and try to see that how long the child can control the bladder and control the micturition. But most of the times I have to allow them, otherwise they become very jittery. And this is more common in boys. As I said, there is no incontinence, there is no dysuria, no abdominal or frank pains, and no change in the bowel habits. So this condition differs from the previous overactive bladder because this does not have any other symptoms other than increased frequency. Like the previous child had bedwetting also at night, daytime also, constipation also, and other features also. But these are just simple children who have only increased frequency. There is no polydipsia, no polyuria, and no nighttime symptoms in these children. So you may consider ruling out cystitis and hypercalciuria because sometimes that can irritate, and just get a routine urine examination and a urine calcium creatinine ratio. This test is not very expensive, but most of the smaller labs cannot do it properly. So if you want to get a calcium creatinine ratio, go for a good lab, ask the pathologist if they can do, or go for a very standard lab which is time tested and they can do this test. Management will be reassurance of the parent and the child, identification of any emotional trigger, if any. Most of the times I find there is some discordance between the parents and the child is upset, or there is some problem in the peer group and with the friends or with the school and teacher, and there is an underlying emotional trigger which can lead to this problem. And the only thing I want to highlight is that there is no role of any medications and drugs in it. And even if you give tolterodine or oxybutynin, it really doesn't work, and it may aggravate sometimes, and constipation may aggravate. It resolves within days to weeks. So we just have to keep reassuring the parents and the child that this is a innocuous thing, this will go away, and don't worry about it. Unless there are other symptoms which are accompanying, we just leave the child alone. Now, there's another condition called giggle incontinence. It is mostly common in young girls, 7 to 15 years of age. And here there is a large volume incontinence during immediately or after giggling or laughing, and seen in girls around 7 to 15 years of age. So it's not very common condition, but sometimes, yes, we do come across. And there's a sudden relaxation of urinary sphincter, and the child would pass whole of the urine. The bladder empties completely. It's not like dribbling or just wetting the underpants or soaking. It is just complete relaxation and complete emptying of the bladder. So how do we manage? Again, most of these children with pelvic floor muscle retraining and Kegel exercises can control it, but occasionally these children may require methylphenidate, and we give a dose before going to school, but be cautious that it has got some CNS side effects, so we don't require for all children, and only select a group of children with, of course, a consultation with the pediatric nephrologist. We should treat these children. Now, another condition what we see commonly in our setup is post-voiding dribbling. Here, typically, the young girls have a vesico-vaginal reflux. How it happens that some of these girls, they tend to keep their legs adducted. That is, there are hairpin position while voiding, and that consecutively impedes the outflow of the urine. So the only treatment here is that they are also seen in overweight girls because their labia does not get separated, and the deflected urine goes into the vagina during voiding and dribbles out once the child stands. So typical history is that the child will tell you that when the child is sitting on the pot passing urine, she is fine, and once she just gets up, some amount of urine leaks out and it wets the underpants. And this can be confirmed by an MCU or by demonstrating the lack of dribbling if the child voids in the correct posture. So what do? I have to do is correct posture for the child is important. What is that correct posture? We have to encourage the child to adopt the correct posture of voiding by removing the underpants completely while voiding. Most of the times the girls would not completely remove the underpants, and that causes adduction of their legs, causing impedance of the passing the urine, and pressure on the external sphincter. And she should sit with the legs apart and lean forward. So this is a very simple thing which can be taught to the child, and this can relieve her of these symptoms. Sometimes this is what I have devised is for the obese girls, I advise them to sit on the toilet seat facing backwards. So automatically, if the underpants are completely removed and they are sitting with the facing backwards, the tank is big, so automatically the legs would spread and the child will pass the urine completely, and there will be no reflux of urine into the vaginal area, and she can be relieved without any medication, just by physical means, explaining and teaching her the correct posture during voiding. Now, these are all simple conditions which we would normally see in our day-to-day practice, but there are few of these conditions where we have difficult children, and these are the holding maneuvers, the dysfunctional voiding, and they are the ones who are a little troublesome, and the symptoms they would have is suprapubic pain, holding postponement, voiding postponement, holding maneuvers like Vincent curtsy. Look at this child. This is what we call as Vincent curtsy. The child is having a cross-legged position, and this is a holding maneuver to avoid leaking of the urine. Sometimes the boys would pinch the glands of the penis between the fingers, or squatting on one heel to avoid the leakage of urine. They have urgency, they have urge incontinence, and interrupted urinary stream. So if you see, they have a horde of symptoms, and sometimes this is the position you would find the child would be sitting like this or crossing the legs to avoid the leakage. And if you do an MCU, these are all my own patients. And if you do an MCU, this is typically what we find, that their urethra is little dilated, and the appearance is like a spinning top appearance of the urinary bladder. If you remember, we used to play the tops, what was called as the lattu in North India. And this is the characteristic shape of the spinning top. And this is how we find the MCU with the dilated ureter and the bladder shape. And most of the times, the post-void residuals there, they do not empty the bladder fully. And we have to teach them as to how to empty the bladder fully. So these are difficult children, and they require a joint consultation with a pediatric nephrologist for complete evaluation. Management of UTI is very important because they would have holding maneuvers and recurrent UTIs. Management of constipation, again, these children would be really constipated and difficult to treat, so they need good management. They would need antibiotic prophylaxis till constipation has been treated, because they would again have recurrent UTI because of the holding. Timed voiding is good thing. Every 2 to 3 hours, the bladder should be empty, and double voiding. So I tell them that once the child is going for the washroom, one of the attendants should watch the child has passed the urine, and once the child is wanting to get up, just tell the child that wait for a half a minute, 1 minute, and again the child would pass some amount of the urine, and that is called double voiding. In that, the whatever was left in the bladder, the post void would empty and the bladder can empty. This will give more filling time to the bladder. Then again, pelvic floor muscle exercises like Kegel exercises are very helpful in these children. Sometimes an alpha blocking agent may be used. Tamsulosin in the given dose can be used in these children. And other therapies, I'll not touch upon it. They are like in difficult cases, nerve stimulation, botulinum toxin injection, sphincter dilatation in some of these patients. So at times we get these difficult cases where we have to consult our pediatric surgeon also, and some intervention is required for these children. There's another condition called underactive bladder, which is infrequent voiding. Again, not a very common condition in your practice. And these children, I get these children because they come with difficult problems, recurrent UTIs, and there's a chronic dysfunction of the bladder and outflow obstruction. There's a poor emptying, bladder emptying, and progressive increasing in the bladder capacity. The urge and sensation to pass the urine is diminished, and the voiding is very infrequent. Just 2 to 3 times in a day they would void, and they achieve the voiding by compressing on the straining the abdominal muscles. And hence a large post-void residue is left. There are recurrent UTIs leading to a large floppy bladder. Of late, I was on a MCU table and in the radiology, and we were doing an MCU for a child who had actually come with this history that parents were saying that the child passes urine maybe once in 12 hours or so, and only once or twice in a day the child would pass urine. When I examined the child, the bladder was palpable and a huge bladder was palpable. And when we did an MCO, I catheterized the child and the little dye was injected, and I saw that the bladder was already having almost about 400 ml of urine in it. And the bladder was totally full. So I asked the child whether the child was wanting to pass the urine, and he said that he doesn't have any sensation and he's comfortable. He was about 8 years old boy. Then I pushed a little more contrast to have a good view of the bladder. After that, we took pictures and I asked the child to go and pass the urine. Trust me, we kept waiting for about 1.5 to 2 hours and the child was not able to pass the urine. I made him go out, have some walk and then come back and pass the urine, but he would not. So again, I wanted to have a micturating film in this child. And the child was very intelligent. I made him stand, the boy, I made him stand on the radiology table instead of lying down that the pressure would generate. And he said, "Uncle, I know how to pass the urine." He compressed on his lower abdomen on the bladder area and immediately started passing the urine, and we could take the pictures. So these children become intelligent because they are not passing urine very frequently, and they know how to compress on the muscles, abdominal muscles, and then start passing urine, but they develop a floppy bladder, and that is what is a lazy bladder is. So how do we manage these children? The aim is to optimize bladder emptying and improve bladder sensation. So this can be done by urotherapy, that is double and timed voiding. Every 3 to 4 hours, we tell the child to go in the washroom, and whatever way the child applies the pressure, but empty the bladder so that the bladder doesn't become floppy. Then some of these children would require clean intermittent catheterization, that is CIC, intermittently during the day, and we train them how to use the catheter after cleaning, washing properly, and with the aseptic techniques. And these children are fairly older, 7, 8 years, 10 years, and they can catheterize on their own without a problem. Or the other thing is that they would have double and time voiding during the daytime if they don't want to catheterize too often. And at night, we put in the catheter and there's a continuous bladder drainage so that the bladder doesn't become over distended and floppy. So most of the times they would, school-going children, they would say that daytime they cannot catheterize. Okay, you go to the washroom, even in school every 2 to 3 hours, and then void and completely empty the bladder. And at night time, put in the catheter and continuous drainage so that the bladder becomes a normal size and contracts. These are usually difficult cases, and again, a joint management is the one who is recommended for these children. Now I come to the second part of my talk, that is the nocturnal enuresis. Again, a very, very important condition subject, because you would have a lot of these children coming with nocturnal enuresis. And just a brief thing about nocturnal enuresis, that the majority of the children are dry during the day by 3 years of age, and at night by 4 to 5 years of age. So if the child is not dry by 4 to 5 years of age and wetting the bed, that is not normal. So enuresis or bed wetting, when do we call it? When there is involuntary voiding during the sleep. That means the child does not know that the child has started passing urine. It's involuntary. And it is more than 2 wet nights per week in a child over 5 years of age. So these are the two things that it is, if the child has wet the bed maybe once in a month or so, then we are not too much concerned and bothered in a smaller child. But if the child is over 5 years of age and wetting at least 2 times per week, then it's a cause of concern, and we call it as enuresis and nocturnal enuresis. This is a common condition affecting 10 to 15% of the children over 5 years of age, and it is again more common in boys. Though it is a benign condition, but can often have significant psychological or emotional problems in a child, because the school-going children, they would feel shy that nobody knows about it. But somehow they have a guilt feeling that they are wetting the bed and scolding by the parents and being shamed by the parents or the other family members. And they become emotionally disturbed, and this disturbs their education also and school status also. And children need active management if the child is over 6 years of age. So any child who's coming, when the parents say that the child is wetting the bed, so most of the time the grandparents would say it doesn't matter, they keep doing it and they'll get better. But if the child is over 6 years of age and is concerned, I think we have to help this child, and it is not a normal condition. So what are the causes and etiology of enuresis? It is not very clear. One of the parent or other family members was usually traced to be enuretic. And if one parent is enuretic, there's 44% chances that the child would be enuretic. But if both the parents are enuretic, there would 77% chances that the child would be enuretic. And at times the parents don't realize that they are the ones who have that problem, and there may be a genetic factor which is leading to this problem, and scolding the child will not help. Very interesting that about 11-year-old boy was brought by parents, and they said that the child wets the bed very often. And I was taking the history, and I was talking to the child also if he has any other symptoms, just to make him comfortable. And during the history, I asked whether one of you were also having enuresis during your childhood. And lo and behold, both the parents looked at each other, and they admitted that both of them were having enuresis during their childhood. So I pointed out that probably this child has got again a genetic problem, and it's not his fault that he is passing, it's in the family. And the child was so happy that it is not because of his fault he gets rebuke every day. It's because of his parents that he is passing, he's doing bedwetting. So we could sometimes encourage the children that it's not only your fault, sometimes it may be a genetic factor. So we have to look into that part. Other postulated causes are maturational delay. We all know children who have maturational delay, or emotional stress again plays a part. Deep sleep is known, but I doubt whether that can be a reason for it. Reduced functional bladder capacity if the bladder is small, so we'll see how we can measure that. Or lower nocturnal ADH secretion. This is, I think, a very important factor. Sometimes infection, bacteria, food allergies, sleep apnea again is very important factor we'll see in the later slides. And anatomical urinary disease, of course, can lead to enuresis in these children. So I show you a case scenario. This is a 12-year-old boy. He was brought by the parents because the child wets his bed very often at night. So what other information would you like to have as an initial evaluation of the child? Based on the onset, we would like to find out whether the child had never achieved urinary control, which is called as primary nocturnal enuresis. Again, differentiation is important because the management depends upon the onset of the enuresis, whether it was primary one, whether the child never had a control, or was it a secondary enuresis. That means it's of recent onset enuresis in children who have had previously dry nights for at least 6 months. And we have to look for precipitating causes like cystitis or any psychological reasons in these children if it's a secondary enuresis. So it's very important for us to differentiate between the two because the management will change in both these conditions. And if it's a primary nocturnal enuresis, then it could be monosymptomatic. That means there is no daytime symptoms. Again, important to differentiate between both, or it could be child associated with daytime symptoms like incontinence is there, there's urgency or abnormal daytime frequency, voiding less than 4 times in a day or more than 7 to 8 times in a day. So again, the management will also change if it's a monosymptomatic or associated with other daytime symptoms. So in the history, it's very important to find out whether it's primary or secondary, and whether it's monosymptomatic or there are other daytime symptoms also. Other comorbid conditions again have to be looked because they can cause therapy-resistant enuresis and they can delay the response. Constipation, as I said, is very important, and many of these children would have constipation leading to this problem and vice versa. Sleep disorder breathing, we would see that children who have obstructive pathologies, they have problems of bedwetting. Obesity again can lead to this, and we have to control obesity. Behavioral and developmental disorders like ADHD and autism spectrum disorders have also to be addressed because these comorbid conditions can delay or have treatment failure of enuresis. So once we know about this child, now we have to evaluate. First, we have to see that the child has never been dry when asleep for more than 6 months. We would label him as primary nocturnal enuresis, PNE. But if the child has got polyuria, polydipsia, there's a weight loss also, I think these are the children whom we cannot label just as enuresis. They may be the ones who have got chronic kidney disease, underlying chronic kidney disease. They may have diabetes mellitus, diabetes insipidus, or other tubulopathies. So this set of children who have got polyuria, polydipsia, or weight loss, look for other conditions. Again, a child was brought to me with bedwetting, and when I took the history, the mother would not have told me. When I took the history, then this child was waking up very often and drinking, and then mother told me that he has got a water bottle at bedside and he drinks a lot of urine at night also, and keeps passing urine in daytime and night also. He had polyuria, polydipsia. And then when I looked at the child's condition, this child had got a tubulopathy, and it was entirely a different condition where the parents were unaware about it. And for me, it was like a different condition to be treated rather than just nocturnal enuresis. Daytime symptoms may be present, urgency, frequency, holding maneuvers. Again, these are difficult conditions, and nocturnal enuresis may be present in these conditions. So we have to look for these when we are evaluating. Again, constipation comes again and again because we know that this is a very disturbing factor in these children with urinary tract problems, whether enuresis or recurrent UTIs. Again, children with ADHD and ASD have to be evaluated. Adenotonsillar hypertrophy I was talking about, this is one factor which is a treatable factor which can actually cause problem in these children. And it's not only because of mechanical problem, there are hormonal changes which can occur because of the adenotonsillar hypertrophy. And removing these tonsils, we would see that can help. When examining the child with the nocturnal enuresis, do not forget to see the lower back of the child. There may be a tuft of hair or spinal dysraphism, which may itself be a telltale sign that the child has some other anatomical problem, which is leading to enuresis and disturbance in his micturition. So look for that. Look for any neurological examination of the lower limbs and anal area if there is a doubt about the neurological problem, so that we rule out other anatomical and neurological causes. Look for the external genitalia also. I have seen children with labial adhesions and phimosis in boys who had recurrent UTIs leading to increased frequency also in daytime sometimes, and also nocturnal enuresis. So please examine the child fully, see the genitalia also, see the back also, and palpate the abdomen for any fecal masses or any distension of the urinary bladder, which can again give us the clue about other causes of nocturnal enuresis like constipation or lazy bladder. Then observe for the urinary stream for any dribbling or intermittent or weak stream, and ask the mother whether, because these are the causes which will not be like simple primary nocturnal enuresis, but they have other underlying causes where it will be a treatment failure if we do not look into these causes. For investigation, I would first say that first see the urine volume to see for polyuria, because again the treatment management would depend upon it. And you can ask the mother to, I normally give them I have got mugs, measured cups in my clinic, which I give to these parents, that they can measure it. The child can measure the urine every time he goes to the washroom and put in a bigger bottle, and end of the day they can measure the whole volume, and we could see whether the child has got polyuria. which is again can be of different cause rather than only nocturnal enuresis as the primary one. Get a urine routine and culture to rule out any infection. Get a plain X-ray KUB to rule out any fecalis can be there, and for bones and stones I get this X-ray. An ultrasound is important of kidney urinary bladder area, and pre and post void is very important. So when you ask for an ultrasound, I would write an ultrasound KUB area with all measurements, comma PVR, so that the sonologist knows what I am looking out for. And if you write this, he would give you the measurement of the kidneys, whether there is any dilatation of the pelvic system, whether the ureters are dilated, what is the bladder capacity, how is the bladder wall thickness, and what is the pre-void capacity, and then the post-void capacity. So all this information is very important for us, and get an ultrasound and a proper one. If these are normal, trust me, no further tests are required. I've seen these children getting CT scans and MRIs and things like that, but first see whether we are not dealing with an anatomical or neurological cause, and if it is not, then these simple investigations are good enough, and don't get any blood tests and other tests unless the child has got other features. Now coming to the management of nocturnal enuresis. We have already done the clinical assessment, as I've already told you, and frequency, volume, bladder diary is to be maintained, for which again we have to tell them how to measure the urine and see, and also document how many times the child is passing, if it's passing in daytime also or night, and what is the volume the child is passing. The bladder diary is not only the volume, I mean the frequency is very important, how many times the child is voiding. Then coming to the non-pharmacological treatment, I'll talk about it in little detail about educating the child, about demystification and urotherapy, general advice on good voiding practices. And with this, many of these children may have relief in nocturnal enuresis. Then first line therapy is the alarm therapy, which is called enuresis alarm. And the success rate is very high. Almost 70% of the children can improve just with simple alarm. And we'll see how do we use that. That's the first line therapy. Alternative therapies I've mentioned here, like sometimes acupuncture, acupressure, hypnotherapy, but I'm not an expert on it, so I will not talk about it too much. And I'm really not sure whether all these things would help, but parents come that they had done all these things and it was a failure, and now they have come for the treatment with the doctor now. Among the pharmacotherapy, the first line medication is desmopressin. We'll talk about it a little later. Then sometimes add-on anticholinergics like oxybutynin and tolterodine are also required. And very few of these children I use them. But again, it has to be a joint shared care with a pediatric nephrologist if these children require drugs other than the first line. And then the second line drugs, tricyclic antidepressants like imipramine can be used, but again, they have got side effects. And in today's time, when we have got good medications, we used to use in our early days and college days and in our residency time, when desmopressin was not available, very freely available, expensive. But now we have got good drugs, so I think we can avoid these tricyclic antidepressants unless the child cannot afford, or a very poor family, or there's a failure of the first line drug. A combination of alarm and desmopressin has got the highest success rate, and we would see how we can manage them. As I said, management of comorbid conditions may result in resolution of enuresis and adenotonsillectomy. Trust me that these children who have adenotonsillectomy along with enuresis, if you get the adenotonsillectomy done, 50% of these children can have relief of the problem without any medication. So that is how this sort of an obstructive pathology can save the child from all these problems and getting relief by surgical intervention. Constipation, again, I have put in bold because again, that has to be relieved if you want a good management of nocturnal enuresis. Concurrent management of other conditions, I've already talked about it. Now, demystification, that is educating the child. And here I say hugs and not drugs. So first thing is educate the child and parents about the condition, about the normal bladder function and pathogenesis of enuresis. and I have to spend some time with the child, explaining to him or showing him the picture of the bladder, as I had shown you earlier, that this is the bladder muscles and how it functions, and sphincter control and all these. And again, pathogenesis, that what can be the causes about it, and taking the history part again about the parents is also important. Then informing the child that enuresis is a common condition and likely to affect other members of their peer group. And I tell the child that there may be other children in your class who are having this problem. Do you know about them? He says no. And same way I say that about you also, others will not know about it, but there are quite a few children who would have this problem, and this is not uncommon to have. It's a quite fairly common condition, so don't worry about it. So that gives some relief to the child that he is not an odd man out in the group, and there are others also. Then help eliminate guilt and shame. Most of these children are rebuked by the parents, other family members, and they feel very guilty and shameful. So you have to tell them very, very passionately and with a lot of concern about, and the child can read your body language that you are concerned about the child as a child and trying to help. And let the child take the control. Sometimes the parents would be like an helicopter parent, and they would, but I said, let the child take control, let him feel responsible, the results will be better. And we have to tell them that there are effective treatments to resolve it. So I tell them, better don't worry about it, we have treatment and you will get better, so don't worry about it. So the moment you say that you can get better, you can see the smile and the glow on the child's face, that it's not uncommon, and he's not the only one, and he can be relieved of this problem. Then about the other good urinary voiding practices, all children should, these are for all general children, that they should void every 2 to 3 hours during the day, at least 6 times in a day. This is a practice which I find in school. These, especially the girl children, are not voiding properly, and they avoid going to the washroom because either they are not available or they are not clean. And we have to tell them that as a good practice, they should go for the washroom and every 2 to 3 hours. Always void before bedtime, again very important for these children who are having enuresis. They should have at least one soft bowel movement every day. No constipation should be. Fluid intake, I would say at least 30 ml per kg per day, about maximum 2 liters. Don't force them with too much of fluids. That also would harm the kidneys. And this is to be consumed throughout the day, but restrict after evening. So I tell them that take a lot of fluids in the day, but after evening, restrict the fluids. So you can say maybe if the child is taking 1.5 liters, 1 liter he can take in the daytime and ½ liter only after the evening, restricting, and no fluids 1 hour before bedtime. So you have to ask the child, what time does the child sleep? Suppose he sleeps at 10 o'clock. So ask the mother to give the dinner at 8 o'clock. There's a 2 hours gap. The child would feel thirsty after the dinner. So by 9 o'clock, till 9 o'clock, you give him whatever liquids he wants. And after 9 o'clock to 10 o'clock, when it's sleep time, just restrict fluids, nothing to be given. No water, no milk, no juices. And if you say fluids, the mother would think that only water. So she would give a glass of milk, which is 90% water. So we have to restrict all fluids and tell the mother specifically that no fluids means nothing liquid. No juices, no water, no milk, anything. Record wet and dry nights with positive reinforcement. So I tell the children to make a reward chart and weekly chart, not month-wise, weekly chart, and I give them a green pen from my side and ask the mother that whenever the child is not wetting the bed, he would get a green star. And the more the number of stars the child comes with, then we will decide, give him some small gift, which would be an educational material, not gift like chocolate, toffees, or things like that, but maybe something with the child is wanting, a toy or a small dress or some reading material or something, which is like a positive reinforcement. And that also helps that the child wants more and more green stars. I was initially putting in a red star, but then I found that red star is something which is not very, I mean, it's a scary thing to have red. So I started putting a green star in for these children, and green means go green. Avoid tea, coffee, cola. They are bladder irritants. and they can also sometimes emotional disorders to be addressed. Again, take a history whether there's any emotional disorder which is causing this sort of distress to the child, and without considering that, we would have a treatment failure. Trust me, demystification and urotherapy may sometimes make the child dry. If you sit with the child and explain all these things and give him about 2 weeks time, and you would find sometimes that the frequency of nocturnal enuresis has started decreasing. When child may not require other medications. Punitive measures are counterproductive. This has to be told very gently to the parents, that if you try to shame the child or rebuke the child or try to punish the child or talk in front of other family members or other children, look, this child is grown up now, he's 10 years old, he's still wetting the bed and he's not shamed about it. So this is going to be counterproductive and the child will never get better. So give a positive reinforcement. If he has wet the bed, just gently tell him that he would go to the washroom, change, and also change the sheet himself, and not as a punishment, but as a protocol that he has to change the sheet himself. And that also helps, that every night he has to go to the washroom and change the sheet. So this is something he would not want to have, and he would put in efforts to avoid all these things. So now talking about the alarms. So alarm is available. Sometimes it's not easily available. There are two types of alarms. I will talk about it. Useful for motivated children who are usually over 7 years of age, and from cooperative families. So you have to find the cooperation of the family, and the child should be 7 years above, so that he can understand and get motivated. This alarm basically trains the child to respond to a full bladder sensation. Initially, the alarm may beep or vibrate depending upon the type of alarm and depending on as the child passes urine. So the alarm lead is put inside the panty, and the alarm is put on the child's wrist, or it is kept beside the child. And as soon as even a small amount of urine is passed, a drop of urine, the catheter inside picks up the sensations, and the circuit is completed, and the alarm starts beeping or vibrating. Initially, parents have to rise to the alarm and awaken the child, and gradually the conditioning of the child occurs. And so sometimes the mothers, the parents complained that when the alarm goes, everybody in the house is awake except the child. So I have to tell them that doesn't matter. Initially, you have to wake up the child and help the child, and gradually the child would respond to the alarm and get conditioned. And this alarm has to be worn every night. That is important. And the parents have to ensure that the alarm is there. And once the child has, the alarm has burst, and the child goes to the washroom and cleans and changes, then again when he comes back, he has to put on the alarm again. Sometimes the children are naughty that they would not put the alarm. So the parents have to ensure, initially they have to give him a good help to the child. And initial few weeks are a little difficult in treatment, and after that the child learns, and it takes 4 to 6 weeks to begin working. So once the child sees that the result is there, and he is happy that he is not wetting the bed, gradually, even before the alarm comes, the child would have a sensation of full bladder. He would go to the washroom, and the alarm has not even buzzed, and he would go and pass the urine, and that is the success of the alarm. But when to stop the alarm? We recommend until there are 14 consecutive dry nights. So if the child has got 14 consecutive dry nights, then we would decrease the frequency of the alarm. Or 2 to 3 months have passed and there is no effect of the alarm, and he's been sincere, and 2 to 3 months have passed, that means this is a failure to alarm, and this alarm will not result in any good results now. The success rate is fortunately very high, and greater long-term effects rather than any other method. 70% success rate is there. So with this simple device, without any medication, with urotherapy and other precautions, these children can be better and 70% get relief with the alarm alone. Now, children first thing is, now children who have not got alarm therapy has failed, or the alarm is not acceptable. Occasionally the child would come to me that, uncle, I don't want a probe in my panty, and this is very irritating and I don't like it. So he would switch off the alarm. So that means there's an alarm failure, it is not acceptable. Or if the 3 months have passed and the alarm is not effective, that is the time when we need medications. But desmopressin, which is an analog of vasopressin, is recommended only when there is a documented nocturnal polyuria. So we have to measure the urine, see whether this child has got nocturnal polyuria. Only then these medications will help. They are available in 2 forms. There's the oral tablets in the strength of 0.1 and 0.2. They have to be given 2 hours before bedtime. And now recently we have got melt tablets also. We do not need water. They have to be just kept in the mouth just before 1 hour before bedtime. And they are again in different strengths, 60, 120, 240 micrograms. And again, depending upon the child. So these are the children who would require at least one-time consultation with pediatric nephrologist to assess them properly and then put them on joint care with the pediatrician who can monitor these children. The duration of treatment should be minimum of 3 months before we can label that the child is resistant to the treatment. And success rate again is very high with it, 70%. The advantage is that it gives immediate response, and therefore it's useful for less motivated families, and also useful as a short course when the child is sleeping away from home. They are sometimes having, in the school, they would have the sleepover nights and then going to other families and sleeping away. So these medications help. They are very short acting. I mean, they're quick acting and they can help. Now, precaution is that excessive fluid intake has to be avoided once these children are on medication, because there's a risk of hyponatremia. That is the reason that the intranasal sprays have been stopped, because sometimes these children are overzealous and they would take more than required doses and take water and cause hyponatremia. So that was being stopped. So now coming towards the end of the talk, sometimes the parents ask, what should be used first, the desmopressin or the alarm? So I would say the strategy is the family has completed a voiding chart, including measurements of nocturnal urine production. If there is nocturnal polyuria is present and there are normal daytime voiding volumes, desmopressin is tried first. If there is a nocturnal urine output is normal, that means no polyuria, and their maximum daytime voided volumes are very low, 60 to 70% of the expected bladder capacity, then alarm should be the first choice. And if both these are present, like nocturnal polyuria, also daytime frequency, then we would have a combination of alarm and desmopressin can be good. So strategy B is that I ask the parents what would they like to choose, and whatever they choose, we have pros and cons for both. We explain to them, and regardless of whatever they choose, whether they choose the alarm first or the desmopressin first, sometimes it's an expensive medication, so they would not choose desmopressin. They would like to go for a simple thing like alarm. And if did not make the child, first strategy did not make the child go dry, then we can offer an alternative therapy. And if combination both fail as monotherapy, then combination of two can be considered. So very clear guidelines when to give medication and when not to give medication. And if there's a failure, what to do, as both these can be combined. Right. Thank you very much for a very patient hearing. I may have taken a little more time, but I wanted to be patient with you. Like all these children need patience. And these are my helplines. You can take a picture of it. They are open 24/7. And anytime, day and night, you need any help regarding any renal patients, any nephrology patients, not only aneurysms or the voiding dysfunction, anything, you can call me at any point of time and I'll be more than happy to help you. And with all these things, the child's bladder is very happy, and he can be helped with all the strategies which we have discussed. Thank you very much.
Thank you. Thank you very much, Sudev. A brilliant presentation, I would say, as usual. Very cool and calm in presentation, and very informative, very comprehensive. You covered so many things in 45 minutes or 50 minutes. I have one question that is regarding alarm therapy. No, they are not easily available. I usually ask them to purchase online, but somehow I find the acceptance of alarm, less as compared to Western world. I do advise them, I do counsel them, I spend a lot of time with them, but still somehow I am not very sure why, because probably other pediatricians are not advising it so much. So parents do not find it a very useful or a easy to use kind of therapy. So what are your comments on that? And then we have Dr. Gunsa with us and Dr. Jalpa Dave also. They are two very eminent pediatric nephrologists in Gujarat. So I would welcome their comments also. Yes, Dr. Vasudev, please.
Yeah, alarm, because of, as I said, sometimes it's a mechanical thing, and occasionally I've seen children saying that they don't like the probe in the panty to be put. But alarm is available, Dr. Satish. It can be purchased online. Don't put it as enuresis alarm, put as bedwetting alarm, and it is available. There are two types. One is costing about 5,000, the other is costing about 7,000, and both are similar, whichever the parents want to choose. And again, motivation. That's very important. And the pediatrician has to spend time with not only the parents, but with the child to convince him that this can help him and he can get relieved of the symptoms. And alarm therapy is non-pharmacological, so but we can try it at first. And if the child is really not accepting or it's a failure, then we go in for the drug therapy.
Yes, Dr. Jalpa and Dr. Fagun, if you are there, if you have any comments.
Yes.
Hi,
yes,
Fagun.
sir.
Nice seeing you.
Hello, sir. Hello, sir. Nice seeing you, and a very excellent presentation, sir. Thank you very much for this very nice presentation, and thank you, Satish, sir, for the acknowledgement. Well, I do believe that the treating voiding dysfunction is really a hell of a job, and Dr. Vasudev, sir, has made this really very tough job very simple by a very lucid presentation. And believe me, that managing the patients with voiding dysfunction is not so simple as in this talk, and it really requires a lot of patience on the shoulder of the doctors, as well the treating doctors, as well as the parents, because every parent wants the results in a jiffy, and which is not possible in the patients with voiding dysfunction. So I think it requires a lot of patience on the part of the doctor as well as the parents. And I think the most important thing here is in addition to the pharmacotherapy, is good urotherapy, as Dr. Vasudev mentioned in his last couple of slides. And I think that a proper urotherapy, that is a good voiding pattern, timed voiding, complete voiding, proper fluid therapy, and avoidance of all the carbonated drinks and improper food fads, and the most important, the avoidance of constipation, most of the time solves many problems up to the tune of 70 to 80%. And I always believe that the pharmacological therapy works only when the first part is covered properly. If you don't cover the first part properly, because our parents always think that we give the pharmacotherapy and the results will come fast, which is not so. So I think that is the most important part. And the evaluation also requires a lot of effort in all these patients. Maintenance of a good voiding diary, as well as proper voiding charts, and a proper history will give you the diagnosis. So I think this was a very nice presentation, and I think so this will be helpful to all in the routine pediatric practice, because as compared to our uncommon problems like nephrotic or UTI, this voiding dysfunction is a very, very significant problem. And I do believe that in routine pediatric OPD, everybody must be getting significant amount of patients on a day-to-day basis with this voiding dysfunction. Once again, Dr. Vasudev, very nice and excellent talk. Thank you very much.
Thank you, Dr.
Thank you.
Pakul, for those
you.
comments. Jalpa, you have some comments?
No, yes, sir, same, like, indeed an excellent presentation, sir. And yeah, as sir has rightly mentioned that urotherapy is indeed very, very important. What I also feel pediatric essence is more of a counseling rather than, treating and giving medicines. So if we see the adult prescription versus pediatrician prescription, we can see the number of drugs which are so less for pediatric. And similarly, and in that also voiding dysfunction, everything like enuresis, lower urinary tract symptoms, whether it is overactive bladder. And nowadays, especially in this winter season, also there are so many patients having increased frequency, this, that. So mainly urotherapy is the main kind of treatment. I would feel almost 80% will get resolved with urotherapy. But having said that, it's very important to differentiate those who will require some form of medical treatment. Like many a times treating constipation and all that thing, after treating it's the important thing is to differentiate who will be requiring medical therapy and the right time to start the medical therapy, because sometimes it is also associated with so many other psychological impacts on, as well as study impacts because of all these conditions. So that's what. But yeah, urotherapy, proper bowel and bladder habits, especially all those school-going girls, not to kind of hold back urine and all those stuff are really important. And after that, to whom to offer medical management and how long, that is also very important. So,
Thank you. Thank you for those comments. There are several messages in the chat box complimenting you, Dr. Vasudev, for your presentation. And all my friends, pediatric friends who are joined from across the country, this for your knowledge that Saturday Club morning meetings are uninterrupted for the last several years. They start at 8 a.m. We end at 9 a.m. usually. And these are also live streamed on YouTube. So somebody who has missed this presentation can access it on our Saturday Club of Baroda channel also. And thank you all for joining in a large number. Chilly mornings, I was told in Delhi and northern part of India, it's a cold wave. So
thank you so much, Dr. Pandya and Dr. Vasudev. Wonderful talk. Bye-bye.
Are there any more questions in the chat box?
Yeah, my question is, Dr. Vasudev.
Yeah, please.
How does adenoid and tonsils, they affect this nocturnal enuresis or this urinary problem? Because we have many children who don't have urinary problem in spite of having tonsils and adenoids.
No, it's only that once these children
since we are running short of time, we'll not take.
Okay, we can talk later.
So what's the YouTube channel name where we can see the recordings?
Dr. Pandya, please unmute yourself. Dr. Satish, please unmute.
Yeah. So
somebody asking about the YouTube
problem with my Zoom. So what I was telling is that these recordings are available on Saturday Club of Baroda YouTube channel.
Okay, the name is Baroda.
Saturday Club of Baroda. Saturday Club of Baroda.
Okay, thank you.
Very nice name.
Link in some of our groups also. I have shared the link with Dr. Vasudev, so he can also put the link, share the link in his groups.
Thank you, sir. Thank you. Bye-bye.
Somebody has asked about the nasal sprays, and I've already told in the talk that they have been stopped because of the overzealous use and complications and side effects. So only tablets or desmopressin is available.
So if there are not any more questions or comments, I think we end the meeting here. Thank you, Vasudev, Dr. Vasudev, once again for joining. And we look forward to such talks from you in future also. Thank you all.
Thank you very much for everyone to join, and Dr. Pandya, and Jai Hind to everyone.
Thank you so much. Thank you. So we meet next Saturday morning again, and we will be having a talk on osteoporosis by an orthopedic surgeon next week. Thank you.